Welcome. Now we will discuss about the first chapter in the connective tissue disorder, that is the systemic lupus erythematosus, that is SLE. Now, in the rheumatology, this is one of the very important topic that we will discuss among all the topics. Plus, you will have a discussion about SLE in other subjects also, such as pathology, and sometimes even in the pharmacology, because there are some drugs which leads to SLE. So, how the pathogenesis happens, why there is a damage to the connective tissue in SLE, and how it is going to occur. So, there are many trigger factors are there, such as those who are having HLA-DR3 positive, TREX gene is there, Epstein-Barr virus infection. Particularly, it is more common in females. If you see the male-female ratio, it is somewhere around 9:1. Plus, there are certain drugs which can also trigger the SLE, such as sulfonamide, hydralazine, isoniazid, and procainamide. So, the mnemonic that we generally use is SHIP, the SHIP drugs. So what happens actually because of all of that, because of the HLA-DR3 TREX1, there is going to be increase in the number of the cells which are undergoing apoptosis. Apoptosis you have discussed in pathology, that is a programmed cell death. Now when the cell death happens, the cell will rupture, the cell membrane will rupture, the nucleus will rupture, and the content of the nucleus will come out. Normally the content of the nucleus is somewhere here. Now when the cell death happens, the nucleic material will come out, and nucleic material is a very new material to our immune system. The immune system thinks that it is a foreign particle because the immune system has never been exposed to such a material. So what is happening is, whenever the apoptosis is happening, the apoptotic bodies will come out. The apoptotic cells are going to release the nuclear antigens. But you know that it is happening in every one of us. The cell death is happening in every one of us. The nucleic antigen is coming every one of us. Then how our immune system is not reacting to such nucleic antigen? Because these nucleic antigens will be easily removed from the system. They will be removed from the system, or they can be cleared from the system with the help of the C3 complement, C3, C4, and CH50. Now, what they are doing is, these complements are basically removing or clearing these apoptotic bodies. But by chance, if there is a deficiency, of these, then these nucleic antigens will not be removed from the blood, and they will remain, and they are going to trigger the immune system. So these antigens now will be taken up by the dendritic cells. The dendritic cells are going to take up this antigen and will represent this antigen to the T cells. The T cells are going to present these antigens to the B cells, and the B cells now will present these antigens to the plasma cell, that will lead to antibody formation. So normally in you and me, when the cell death happens, the nucleic antigen comes out, but we don't make the antibodies. The reason is the antigens are cleared by the help of the complements C3, 4, or CH50. But there are some persons who don't have these, and the antigens will remain in the blood, and they will make the antibodies. Now these antigens and the antibody, they will make a complex called as the immune complex, and this immune complex will deposit in the different tissues and will create the symptoms. So this particular immune deposition that can happen in the skin, joints, heart, kidney, lungs, anywhere it can happen, and will lead to certain problems. This is called as the type 3 hypersensitivity reaction, because immune complex deposition creating the problem is called as type 3. In fact, these antibodies which are made, these antibodies directly can attack the cells also, particularly the RBCs, the platelets, and WBCs, and can lead to hemolytic anemia. So this is, if an antibody mediated destruction is happening, that is called as type 2 hypersensitivity reaction. So in SLE, we have type 3 hypersensitivity reaction symptoms as well as type 2 both. Type 3 is because of immune complex deposition, there are several symptoms are coming, and the hemolytic anemia is a type of type 2 hypersensitivity reaction. So this is a basic idea. If I just summarize that what has happened in the pathogenesis, that there are certain factors that increases the apoptosis. The more apoptotic material is coming out, plus on top of that, the clearance is not happening of that apoptotic material because the complements are not there. Now because there is more apoptotic material is there, and that is working like an antigen against these nuclear antigens, the antibodies will be made, and these antibodies can directly damage the cells, that is hemolytic anemia, and these antibodies can attach with the antigen, can make the immune complex, can deposit in the organs, and can create the symptom, that is type 3 hypersensitivity reaction. So this is the basic pathogenesis behind SLE. Now, how will be the clinical features? As I have told you that it is more common in females. If you see that these immune complex can deposit anywhere in the body from head to toe and can create multiple involvement of the different systems. For example, because of SLE, the patient can have the alopecia. There is going to be hair loss, and this is a type of non-scarring alopecia mostly. Non-scarring alopecia. Because of these antibodies and immune complex, the patient can have the involvement of the brain, that is headache, seizure, but it is not going to be seen in every patient. There can be formation of the rash on the face area, something like this. This is the butterfly rash, the malar rash, the butterfly rash, also referred as the malar rash. It is going to spare the nasolabial fold. Nasolabial fold is spared. These antibodies can involve the lungs, which is very common. They are going to attack the cover, that is pleuritis, and there can be pleural effusion, or in fact the lung parenchyma can involve, that can lead to NSIP. NSIP stands for, it's a type of the interstitial lung disease, that is the non-specific interstitial pneumonitis. And because of this NSIP, slowly the size of the lungs are going to shrink because there is going to be fibrosis. So this is also referred as the shrinking lung syndrome. In the SLE, the size of the lungs are going to be reduced because of the fibrosis. There can be a lot of multiple painless oral ulcers can be there. Multiple painless oral ulcers. The heart can also be involved. There can be pericarditis. Even there can be involvement of the coronary artery, because in SLE patient, the atherosclerosis occurs very fast. So there is a chance of myocardial infarction. There can be involvement of the kidney, that is referred as lupus nephritis. One of the in fact the most common presentation is, because of these antibodies and immune complex, there is going to be asymmetric non-erosive arthritis. The non-erosive word is very important. That non-erosive means basically whenever the arthritis happens, we need to see that is there any damage to the surface of the joint bones, is it there or not there. So there is no damage. This non-erosive arthritis that is going to be there. There can be involvement of the muscles, means the patient can have myositis. There can be ascites also. Plus, as we have discussed, that these antibodies can directly attack the cells, and if the RBCs are attacked, the patient will develop the anemia. If the platelets are attacked, the patient will have decrease in the platelet number, that is thrombocytopenia. And there will be decrease in the number of the neutrophils also, that is neutropenia or the leukopenia. So these are the various features that can be there. It's not mandatory that all the symptoms will be there, but the patient can have any of these symptoms when it comes to SLE. Among them, the most common presentation is going to be the joint pain. Mostly the SLE patient presents with the joint pain, that is the asymmetric non-erosive arthritis. If the lungs are involved, the most common pulmonary presentation is going to be pleuritis. The patient is going to have chest pain because of pleuritis. And if there is a pleuritis, if you auscultate, you will be able to listen that the pleuras are rubbing one another. There is the friction that is happening between the pleura because of the inflammation. So on auscultation, we can have the friction rub. The most common cause of death, overall the most common cause of death is going to be myocardial infarction, because in SLE patient, the atherosclerosis occurs very fast. But if they particularly ask that a patient of SLE, what is the most common cause of death in an early SLE patient? See, in late SLEs, means advanced SLE, the patient will have MI. But in early SLE, we don't have MI. Generally, if a patient of SLE is having death very early, then most likely it is because of infection, because you can see that there is decrease in the WBCs, leukopenia, neutropenia is there. So there is an increased chance of infections are there. When it comes to the cutaneous involvement, one of the common finding that is there in the acute SLE, there is going to be the butterfly rash, a very classical butterfly rash. This butterfly rash, you can see that it is not involving the nasolabial fold. I am highlighting with this blue color. This area is not involved. So there is a butterfly rash plus the sparing of the nasolabial fold. The nasolabial fold is spared. In the subacute one, we can have such rashes. And in the advanced stage, that is the chronic SLE, we are going to have the discoid lupus. And when we have the discoid lupus, in that case, we might get scarring alopecia. Normally, the alopecia that we are having in the SLE is non-scarring. But in the advanced stage, when we have the discoid lupus, means the chronic involvement of the skin, at that time we can have the scarring alopecia. The involvement of the kidney in SLE, it is referred as the lupus nephritis, and the WHO has given a classification when it comes to the lupus nephritis. If the SLE, there is very minimal involvement in the kidney, very minimal involvement in the kidney, that is called as the stage 1 lupus. That is a minimal involvement, minimal mesangial involvement, minimal mesangial lupus nephritis. But slowly there will be inflammatory cells are going to be deposition. So that is called as the mesangial proliferation. That is the stage 2. Then there will be involvement of the glomerulus. Firstly, the involvement will be less than 50% of the glomerulus, and slowly the involvement will increase. If the involvement is less than 50% of the glomerulus are involved, that is called as the focal lupus nephritis, and if more than 50 is involved, that is called as diffuse lupus nephritis. And mostly the presence of the patients of the lupus nephritis is going to present in the stage 4. In the stage 4, we are going to have a very special lesions. These are called as the wire loop lesions. So it is an important MCQ from pathology aspect. The wire loop lesions, they are seen in SLE, and they are seen in which stage of SLE? That is the diffuse lupus nephritis, that is stage 4. Then there will be membranous lupus nephritis, and ultimately there is going to be sclerosis, the advanced sclerosis lupus nephritis, that is stage 6. So initially there is going to be minimal involvement, then there is going to be mesangial proliferation, the inflammatory cells will come, and then there will be focal lupus nephritis, then the diffuse, and then there is going to be membranous, there is going to be thick membrane formation, and ultimately there is going to be hardening, that is sclerosis. When it comes to the investigation in a patient of SLE, if a patient is presenting with the acute flare, there is going to be increase in the acute inflammatory markers such as ESR, CRP, there is going to be increased. When it comes to the most sensitive test is anti-nuclear antigen, ANA. Against the nuclear antigen, there is going to be antibody formation, that is the ANA, anti-nuclear antibody. Then we have the most specific test. It is the antibody, that is anti-Smith antibody. But anti-Smith antibody is very specific, but it is not very sensitive. It is not seen in a majority of the patients. So there is one antibody which is very sensitive as well as very specific also, that is anti-DS DNA antibody, anti-double stranded DNA antibody. If we are thinking of drug-induced lupus, I told you the drugs that leads to SLE, it is the SHIP drugs, the sulfonamide, the isoniazid, hydralazine, procainamide. If we are thinking of that, then the drug-induced lupus, generally it is associated with anti-histone antibody. Histone we have discussed in the nucleic acid, if you remember, the DNA has a very tight relationship with the histone. So if a wrong antibodies, these antibodies are attacking the histone, that is anti-histone antibody, the patient can have the drug-induced lupus. When we talk about the neonatal lupus, means the mother was having SLE, now the child is also having SLE, then most likely it is the antibodies which are there is anti-Rho antibody, which is also called as anti-SSA antibody or the La antibody, that is SSB antibody. When it comes to photosensitivity, it is again associated with anti-Rho antibody. If a patient of SLE is having psychosis, then most likely the antibody that we will find in his blood is anti-ribosomal P antibody. We can remember like this: P is for the psychiatric symptom. If there is involvement of the cerebrum, then we are going to have the anti-neuronal antibody. If a lady is having SLE and she is having recurrent abortions, there are certain antibodies which makes the blood very thick, then can lead to recurrent occlusion of the uterine artery. So the recurrent abortion, if it is there, then most likely it is because of anti-phospholipid antibody, anti-glycoprotein 2 antibody, or anti-cardiolipin antibody. So these antibodies can lead to recurrent abortion. So the point is, what are the various tests that we are going to do? One of the first tests that we do in the SLE is going to be ANM. It is very sensitive. Then the other next test that you will do generally will go for ANA. Then we go for anti-DSDN antibody. That is the investigation of choice. And the next antibody that we can try to search is depending on the symptoms. If the patient is having photosensitivity symptom, we will go for anti-Rho antibody. If having psychiatric symptom, we can go for ribosomal P, and accordingly we will decide that which antibody is to be tested. Right now, once we have made the diagnosis, for that we are going to use a criteria called as the SLIS criteria. In the SLIS criteria, there are two types of features that you have to check in the SLE patient. They have identified some clinical features and there are some immunological features. I will tell you what are these features are. So they have given us a list. The SLIS criteria has given us a list of clinical features can be seen in SLE, and there are some immunological features. So what you have to do is, you have to see that how many clinicals are there and how many immunologicals are there. The sum of these two should be more than 4. Should be more than 4. So what are the various clinical features that we have? In the SLE, the clinical features that they are saying: acute cutaneous lupus, chronic cutaneous lupus, ulcers, alopecia, synovitis, serositis, renal involvement, the neurological involvement, hemolytic anemia, leukopenia, thrombocytopenia. So these are the clinical features that we need to search for. Plus the immunological features that we can search for is generally the antibodies or the complements, such as the ANA, anti-DSDNA, anti-Smith, positive antiphospholipid antibody, or low complements, or direct cum test. So these are the antibodies that you are going to search, or the complements deficiency that you are going to search for. There will be some clinical feature, some features from the clinical feature side and some features from the immunological side, and the sum of them should be more than 4. But it is mandatory that at least one should be coming from each side. It should not be like this कि all the 4 is coming from one side. No, at least one should be from each side, right? Maybe 2, 2, maybe 3 plus 1, right? Something like this, the combination should be there. So must have a total of 4 features, and every category should have at least one clinical feature as well as the immunological feature. Or if not, then if a patient is having SLE, we did the kidney biopsy and we are having a biopsy proven lupus nephritis with anti-DSDNA, then also we can say that okay, this is SLE. Now it is time to treat the patient. If the patient is not having a life-threatening symptoms, then we are going to give low-dose steroid. We can give low-dose steroid. We can give HCQ also. If a patient is having life-threatening SLE, then we have to give high dose of steroid. If not, then we can add cyclophosphamide, mycophenolate for at least 6 months. And if there is no response, then we need to add rituximab. Rituximab is an anti-CD20 antibody. It is a monoclonal antibody, this drug. It is anti-CD20 antibody, or we can add belimumab. So this is how we are going to approach a patient of SLE. Let's summarize what we have discussed in the SLE. SLE, there is increase in the apoptosis, so the nuclear material comes out, or our immune system is going to make the antibody against them. These antibodies will directly destroy the RBCs, that leads to hemolytic anemia, and these antibodies will make the combination with antigen called as immune complex. They will deposit in different organs and will create the symptoms. They can deposit in the heart, lungs, oral cavity, brain, anywhere, right? And they can create the different symptoms. We have discussed those symptoms. The important idea is how to make a diagnosis. Whenever we are suspecting, we will go for these antibodies. We'll search for anti-nuclear antibody, ANA, that is the most sensitive, the specific ones, and depending on the symptom to symptom, we'll do the find the antibodies. Then we are going to use the CLIS criteria. There are some clinical features, some immunological features, and the sum of them should be more than 4. If not, then we'll go for lupus nephritis plus anti-dsDNA. If it is there, it is SLE. And for the treatment, one of the mainstay of the treatment is going to be steroid.